Hello, I'm Renato Lopes, and I'm here today with my good friend Remo Furtado from Brazil. And we are going to discuss a piece that we just published in JACC about the recent ACS guidelines that were published. And the idea was to really give a Latin America perspective to put the guidelines into context. So, Remo, welcome. And it was a lot of fun to work with you and other colleagues from Latin America on this piece. And we made several important points in this article. And I wanted to start by the importance of really trying to adapt the general recommendations of an American guidelines to Latin America local reality in each country and even in each healthcare system. So what are your thoughts? And try to summarize what we put together in this article.
Hi, Renato. It's a big pleasure to work with you in this opinion piece and also to be at this interview with you. So you made a very important point. Latin America is a big region in the world with some specific challenges, including socioeconomic disparities. And when we see a guideline such as ACC/HA guidelines for ACS, they are very important because they bring evidence into practice, saying what should we do, what we should not do. But it's important to tailor those recommendations, including expensive recommendations that may arise in those guidelines, to the specific reality of a region with so many important characteristics, specific characteristics, such as Latin America. So my concern is that the clinicians from Latin America, when they see the US guidelines, they would say, okay, this is very important, the way US is doing, the way ACC/AHA recommend. However, they also have to be critical about the application of those recommendations to their specific countries. We are talking about countries so different, such as Brazil, Venezuela, Costa Rica, Mexico, etc.
Yeah, and not only among the countries, but even within countries, as we've seen in Brazil, for example, we have so many variations, so many heterogeneity in how the care of patients with ACS is done across different regions of the country. So again, taking those into consideration, it's really important that we can then not only apply the best evidence, but making sure that that evidence is somehow adapted for their local reality, and then patients get the best treatment that they possibly can. Another point that we discussed that I think is very important, Remo, was how relevant it is to really have local data. And of course, all Latin American countries, they participate in many global trials, which is great. Brazil always participate with high number of patients. Other countries in Latin America always participate with high number of patients. But having local data, local evidence, trying to identify gaps, and also trying to assess outcomes and assess medications and assess patterns of care, it's really important for us to try to adapt something that is done based on global studies and generate high-level recommendations on the guidelines. But then how do we adapt those things to the reality without knowing how this reality is? So having local data seems to be a very critical piece for Latin America, which we are doing better, but we are still not there yet.
Yeah, it's a very important point, Renato. And if we look at our paper, we mentioned some initiatives in Latin America in some clinical registries, and some of them, they really caught my eyes when I first read the literature. One of them was a registry of primary PCI in excellence PCI centers in Latin America, several countries. And the door to balloon time was pretty good, 56 minutes. Okay. However, the pain to hospital time was very long, more around 300 minutes, meaning that in Latin America, maybe the big issue is not about the hospitals, it's about the education of the patients. Another important point is that if we look at some mega trials that support guidelines, let's say the danger shock trial, which was a very important one, suggesting a decrease in mortality with the microaxial impella flow system in cardiogenic shock. That trial was awesome. However, it was done only in Europe, in some specific countries. So my question is, how do those results apply in Latin America? We don't know. We really don't know because we don't have this population included.
No, that's a great point. I mean, when you mention about, let's give an example, reperfusion therapy, that we all know that we save muscle, we save lives. So it's a class 1 recommendation for patients, for example, with ST elevation myocardial infarction. And still, even when we do registries in some countries like Brazil and in high excellence, in high excellent study centers, we still see only about 75% of patients with a STEMI being receiving reperfusion therapy. And in terms of primary PCI, only about 50% or so. So there's still a lot of space to be able to explore other options like lytics or even pharmacoinvasive strategies, or even create network. And we have done that in one state of Brazil, where you can create network of STEMI care using telemedicine and trying to create a flow of patients where a STEMI is recognized early on and then is referral to the closest hospital that has a PCI capability. If not, then you can give lytics and then send patients to those places. So being able to implement that type of initiative is very, very important. In this particular study that we did, we were able to basically in 2 years in that particular city, where we did that in Salvador, Bahia, we reduced the annual mortality rate post-STEMI from 20% to less than 5%. So again, those type of things, they are not so complicated because are basically using knowledge that we already have. Is just trying to implement that in practice can have a huge impact in how we treat these patients and how these patients end up doing after the PCR, after the ACS, and after the STEMI that they present, impacting directly their prognosis. So again, I think those type of initiatives are very important for Latin America.
Yeah, sure. And reminds me of some initiatives that you yourself developed, like the registries in atrial fibrillation, such as the RECALL registry in Brazil and the ALA cross registry in Latin America. And if you look at the realities, we see, for example, in AFib, an increase in events and even bleeding in Latin America. And in the case of ACS, those specific characteristics for those Latin America countries, I would like to also add that in a country so large such as Brazil, we have local disparities. You talked about Salvador, Bahia, which is a state in the northern region of the country, and we know those regions are more underdeveloped. In the registry about primary PCI, the ACCEPT registry, this number, 75%, is the average. However, if you compare, for example, São Paulo, the southeast region, to the northeast, the discrepancy is very high. It's something around 80 versus 40% of patients undergoing reperfusion, meaning that within the countries, we need to tailor those specific disparities.
No, I think that's right. And then once we start having really high quality evidence to map out the gaps that we have, then can come up with local guidelines to try to recommend what might be best for that particular region of the world. Of course, always having in mind the best data that we have globally available, but how to adapt that in the best way continues to be a challenge. And one of the last pieces that we discussed in our article, Remo, that I think is so important is the role of implementation science and medical education. And when we say that, it's not just medical education for physicians, but also we've shown that when we do implementation trials, that having strategies that are multifaceted and multi-level, meaning that includes patient and family and caregivers, but at the same time that include physicians and healthcare professionals, and also feedback to the healthcare system, either if it's a clinic or if it's a hospital, or if it's a ER, but that kind of feedback to the hospitals, all of these multi-level interventions where we can educate and develop quality tools to improve the application of evidence-based medicine, it's very critical. We've done a few trials. We proved that work, that every time we do this, it works. But how can we really expand that more to all countries in Latin America?
Yeah, so this is very important, Renato. One experience that you yourself have participated in the past was the Bridge ACS trial, or cluster randomized trial, suggesting that medical education could improve adherence to guidelines. But I think a step forward in that is that we should not only aim for the local hospitals to improve the guidelines, because maybe we have already done a good job, but we also have to make sure that the patient out of the hospital will be adherent to the drugs, to the medication. Right. We know have a very complex medication regimens, dual antiplatelet therapy, multiple treatments for dyslipidemia, for example, and we don't know whether the patients will adhere to them. So it's important to make some initiative for adherence of the patient. Right. And back to the arrival of the patient, to the education of community and the patient about the symptoms of myocardial infarction. This Perfect. Number of 300 minutes from symptoms onset to go to the hospital or to the ED is very, very long. So we have to educate patients to look for care, to look for quick hospital or emergency care in the case of symptoms suggestive of ACS. And we have a very big room of improvement in that, in my opinion.
Correct. No, I think that's correct, Remo. And again, the importance of the multi-level medical education is not just, it's important for people to keep in mind that it's not just about training physicians. In this Bridge ACS trial that we did over 10 years ago, we found that one of the key aspects to really change behavior was the presence of a case manager. In other words, a nurse that could manage the patient with ACS in the hospital, assuring that all the key drugs, aspirin, P2Y12 inhibitors, heparin, statins, everything was done in the appropriate time, including at the time of discharge. So again, those type of active interventions, such as having a case manager in the treatment of ACS, in the setting of ACS, which is what we show in the Bridge ACS trial, this type of active intervention has a really high impact in how we can change behavior of people, including physicians. So again, really important, put all this in perspective. So I think we discussed some examples of how can we apply the best evidence, taking into account the local reality. We also discuss the importance of starting generating more and more our own data in Latin America, so we can identify gaps and also test new strategies in terms of what might work and might work less, or not work, or not even work. And then finally, the importance of the implementation science and education that needs to come, not just focus on physicians, but also on patients and family members and caregivers and everybody that is involved in the healthcare scenario. So I hope that people will enjoy this piece where we basically put together the Latin America perspective into the AHA, ACC, ACS guidelines, which is a very well written document But again, I think it needs to be put in perspective, and I hope people will enjoy our article. Thanks for watching.